All right, good morning, everybody. Good morning and happy holidays. Thank y'all so much for being here this morning. We are gonna, to be respectful of everyone's time and to get into all of our good info today, we are gonna get started. But I would say to folks who are joining us in the room, please continue to get refills on your coffee. Grab another breakfast sandwich if you are interested. We do have a virtual audience live streaming with us today. And we don't have our in-house sound system. It didn't come to work today. So for our virtual audience, you guys, if you do have questions for our speaker, please feel free to drop those into the chat. And then if you have questions in the room, please raise your hand. Our speaker is going to try to be sure that she relays those questions to our virtual audience, since our mics are a little more centralized today than we usually are. So thank you again, just those housekeeping items. But thank you all for being here. My name is Laura Stewart, for the faces that are unfamiliar, and I serve as the Vice President of Community Development at the Forsyth County Chamber of Commerce. And in that role, I have the pleasure of being the staff liaison to Forsyth County's Healthcare Association. So thank you all for joining us. Part of what the Healthcare Association tries to deliver is content that can be helpful to you in a business space. So we know that you are dedicated to providing care to our community, but we at the Chamber want to be sure that also your business is thriving. So trying to provide quarterly sessions for us to dive into topics, to share information with one another, and to hear from some experts. So I appreciate you guys being here today. I'm so grateful, as always, to Northside Hospital Forsyth for giving us this space to meet in, and grateful to them, and wanted to introduce my good friend and liaison from Northside, Kathy Galbraith, just to say a few words of welcome. Help me thank Kathy for opening her doors to us today.
Hey, you guys. Hopefully everybody knows me too. Kathy Galbraith. I'm one of the directors over here at Northside Forsyth. Of course, thank you for making the trek over here to Northside and listening to our wonderful speaker and topic this morning. I'm sure Jesse or Laura will probably mention, you guys see the frame on your table. Make sure that you or your physician please come to the mingle jingle, since we are finally coming out of, nobody wants to hear the C word, but we're finally getting back to some of our signature events. I do have a quick question too. Who, raise your hand or just give me a wave, who signed up for the January kickoff event? Okay, if you did not and you did not know about it, I'm going to stay until the end. I would love to be able to tell you about what that event is. It is pretty full, but I would love to be able to squeak you or you and some staff members from your office. It's definitely a do not miss event. And if you're virtually, of course, shoot me an email or make sure that you check your email, because the invitation went out several months ago. So anyways, I appreciate everybody being here. Stay well, and I'll see you guys soon.
Thanks, Kathy. Well, these quarterly sessions would not be possible without the investments of our businesses and our sponsors. Our presenting sponsors are Brandywine Printing and Oasis Senior Advisors of North Georgia. And we're so grateful to them for the investment that they make in being sure that we, again, can deliver this content and be sure that we're providing you guys with business resources. So I've asked Derek Brooks, owner of Brandywine Printing, to come and just give a few words of welcome in addition to some materials that are on your table.
Thank you, Laura. So my name is Derek Brooks. I'm the owner of Brandywine Printing. Last year, I was the chairman of the board for the Chamber of Commerce, and I wanted to visit all the things that the Chamber does, and this was one of the rooms that I discovered during that time. And I came in here and I saw that it was a really cool place. It was a safe place for y'all to collaborate and learn from. And I thought it was really neat. So I decided to support it and buy y'all breakfast a couple times a year last year. Now, I usually, when I'm talking to people, insert little humors, and I've done that with y'all. And this is the driest group that I've ever talked to. So I said, okay, I'm taking a different approach today, and let's just see if this hits or not. Somebody says, is it true that an apple a day keeps a doctor away? And the answer is, it will if you're a good enough aim. All right, there we go. We got it. So Listen, Brandywine Printing, we only exist to help organizations succeed, and we do that by improving their image or making them more efficient with printed materials. So if you ever need help telling your story or marketing or forms or any of those kinds of things, think about Brandywine Printing. Give us a call. We'd love to help. Watch out for those apples. Thank you.
Thanks, Derek. Yeah, you guys join me in thanking Derek for his investment in our breakfast and our material and apples today. In addition to Brandywine Printing and Oasis Senior Advisors of North Georgia, our platinum sponsor is Central EMS. Our healthcare heroes are Apple Spice Catering and Stretch Zone, and our care sponsor is Arbor Terrace of South Forsyth. And today's discussion is being facilitated by Dr. Elizabeth Woodcock. How many of you joined us, honestly, a year ago, maybe almost to the date, when Dr. Woodcock joined us last year? Show of hands, waves. Okay, very good, very good. Well, then you all know that she delivered such great information that we just felt like we had to have her back to join us. I feel like we could have had her back in the first quarter of this year because she could have used more time. She had so much great information for us. For those of you who have yet to hear a presentation from Dr. Woodcock, she has focused on medical practice operations and revenue cycle management for more than 25 years. She has led educational sessions for a multitude of national professional associations and consulted a wide variety of clients. So we're so grateful to have her with us. Additionally, she is the author and co-author of 17 best-selling practice management books. And prior to founding her firm, Woodcock & Associates, she worked as a group practice services administrator at the University of Virginia Health Services Foundation, a senior associate at the Advisory Board Company, and a consultant for the Medical Group Management Association. In addition to serving as a fellow in the American College of Medical Practice Executives, she educates as an adjunct assistant professor at Emory University's Rollins School of Public Health. So again, we're so grateful that she had some time to come spend with us today. So please join me in welcoming Dr. Woodcock back to Forsyth County and back to the Healthcare Association.
Thank you so much. I really appreciate it. And I got to say, I'm surprised all the hands went up about being here last year because this isn't always the most exciting, positive, optimistic news, but hopefully we learned something last year, and it's such an honor to have you back again. I will say that I'm hoping we'll have a little bit of positive news sprinkled in here, but there are some challenges ahead, but at least we will be more knowledgeable. As you may have heard, I've been working in the practice management space for a number of years, and sometimes I really do think fondly about the days I happened to marry, actually, or get engaged at the time to a first-year medical student. Lovely guy. I happen to still be married to him today, and I still remember all my friends and family saying, "Oh, you are so lucky to marry a doctor. That's so exciting," except for the first-year medical student thing. And so I was really fortunate that the billing office that was associated, that billed for his medical school and residency, hired me. And it was there that I fell in love with reimbursement for professional services. Now, it's funny to think back about that time. My first job was as the charge ticket runner. You guys probably remember. Anybody remember ledger cards? We still have ledger cards there. So we were very excited to have charge tickets. I had to make it to orthopedics in time by 8:30 a.m. because at 9 a.m. we actually scheduled all 60 patients for the morning. We gave them a 9 a.m. appointment. And then the next wave, 60 patients got the 1 p.m. appointment. And I think back to those days because it was actually pretty efficient. Our doctors would not tolerate any patients not showing up, coming late, coming early. So we just shoved them all there at the beginning. And this is a true story. We did put an RV hookup in the parking lot for that clinic because our patients were showing up the night before to make sure they were first in line. My, how times have changed. So what we want to talk about is the current or coming year. We're only a few weeks away, 2024. And again, we may not have the most perfect optimistic news, but knowledge is power. And I want to share with you a little bit about what's come out, honestly, just in the past couple of weeks. So we'll start off talking about the impact of the public health emergency. And I know we don't want to hear the C word, but the public health emergency did go up this year on May 11th, 2023. So we want to understand the ramifications of that. It expired. We'll talk for a few minutes about telemedicine. We're seeing a lot of softening of telemedicine now, meaning not a lot of people are doing it with the exception of behavioral health and mental health practices. But there may be some opportunities to consider this particular area for your practice in the coming year. We'll talk about the Medicare final rule that was just released in November. So you're the first audience I'm talking to about it, and I've already had 10 more presentations in the next 60 days. This is a very, very hot topic. So really want to, or you could take a look at the 2,790 page report yourself. Either way, breakfast with me or 2,700 pages. And then we'll talk about sequestration, the quality payment program, a bit about CPT codes for 2024. I say that because we could have a whole day conference on the new CPT codes. And then I want to spend a few minutes actually talking about the changing competitive landscape, because this was really limited to urban markets in the past, but we are seeing a lot of changes now in suburban and rural markets, like right here in Forsyth County. So indeed, the public health emergency was established in January 2020. It was a public health emergency before any of us really knew what COVID was, but the word on the streets was it was coming down fast. And indeed, the public health emergency basically suspends the law. When you kind of think about it, it's like if we had an emergency and you didn't, then the highway, the police wouldn't be able to have speed limits, right, coming. So it honestly gives the government the ability to say, we know we have some laws, including the fact that we will not reimburse for telemedicine services. So the public health emergency kind of gives the government the ability to make exceptions. And that's exactly what they did until May 11th, 2023, when the public health emergency expired. And there are two big issues that affect medical practices. The first is Medicaid, and the second is telemedicine, related to the public health emergency being suspended. Several months before it was suspended, the federal government told the states, including here in Georgia, listen, you can go ahead and basically operate Medicaid as you wish again. And you might say, well, what does that even mean? Because remember, during the public health emergency, the government kind of allows itself to suspend its own laws. And so what it did was it told all of the states, you are not allowed to give up any beneficiaries. You have to hold beneficiaries in your Medicaid rosters through the public health emergency. So basically, if you were on Medicaid, it was really, really hard to get off Medicaid. You kind of got it for that entire 3-year period. So several months before May 11th, the federal government said, listen, Georgia, it's back to you. And so what this has meant is that Medicaid is unwinding state by state. And you can see the data here, where I think ranks 9th or 10th in terms of the disenrollment rate. Georgia has disenrolled already more than half of the Medicaid beneficiaries in the state. Let me say that again. Medicaid, Georgia Medicaid has disenrolled 55% of the patients who held Medicaid coverage already since May 11th. So between May 11th and today, half of the Medicaid patients are no longer on Medicaid. Why does that matter? Well, there's lots of ramifications for that, obviously for the patients, but for you, Medicaid beneficiaries aren't always the best at knowing if they're on or if they aren't. And so they're coming into your practices, they're getting MRIs, they're coming in for pain procedures, thinking they're on Medicaid, and you may even check with Georgia Medicaid and they say, yes, they're in, and they're really not. So this has created such a challenge nationally. It's been in the New York Times, because it's one thing to say, yeah, absolutely, states, you got it, we'll give it back to you. But it's another thing for it to be poorly administered. And that's what's happened in Georgia. So make sure that as you look into the coming months, that you really, really hone in on those Medicaid eligibility or Medicaid enrollment denials, because we're seeing a massive spike in them in Georgia. Now, in addition to the Medicaid unwinding that happened in 2023, the other issue is that for the public health emergency, it enabled the government to waive its restrictions related to telemedicine services. If you guys remember, before COVID, I would say the word telemedicine, everybody would be like, yeah, move on to the next slide. We ain't doing that, right? It just wasn't even a thing. And part of the reason it wasn't a thing is because we weren't getting paid for it. Medicare's claims actually were 0.0001% before COVID. And that's because nobody did it. So during COVID, for obvious reasons, you guys remember, right? March, April, May, we were like, we got to see these patients. We got to make sure that everything's okay. So we started to do telemedicine, like within a matter of weeks. It was incredible. And several months afterward, in fact, it was May, early first week of May, the government said, okay, we're going to go back and pay you for all those services for about the past 90 days. And basically, they have let telemedicine reimbursement run. I mean, you can basically get paid for as many services as you can think of in terms of evaluation and management, and those that would not require a physical exam. Obviously, a procedure you can't do over telemedicine, etc. So as the public health emergency was coming unwound, the government said, uh-oh, we've created, some people consider it a monster, some people consider it the greatest thing ever. We've created an environment where telemedicine is okay. So the government stepped in with the Consolidated Appropriations Act of 2023 in December of 2022. So right before they knew that May 11th date was coming down the pike, they stepped in and say, listen, we're going to extend our exceptions for 2 years through December 31st, 2024, as it relates to telemedicine reimbursement. The federal government basically, again, extended its own exception, its right to waive the law for 2 years. So telemedicine is reimbursed, and in fact, we have 266 CPT codes that can be paid at the same rate that you would seeing a patient in-house. That does include 99213, 99214, 99215, 0405, etc. Of course, what I'm listing off is the office-based evaluation and management codes, respectively, for established patients and new patients. So we can see those patients, and there are many services, as you can see, that you can perform and be paid in audio only. So this list, and I do want to point out, you will receive these handouts because I know this is a lot of information and there's a lot of little things on the screen. What I've done is given you the websites for all of these data, all of this information. So if you think to yourself, oh, that is something I really, really want to know more about, in addition to the screenshot that I'll give you, you'll see on the pages that will be sent to you. You also have, most importantly, the website to go to explore more. And the one kind of use case I think that makes a lot of sense for telemedicine, I actually heard this first from a neurology practice, and I've seen other practices, GI, for example, endocrinology, that have done this very effectively. We know that appointment no-shows, not filling a slot, is like the worst thing that can happen to our practice, right? Other than maybe some doctors and nurses are happy. But it is not good for us financially. The reason I say that is you're already paying for all of the staff, unless, does your medical assistant raise his or her hand at the end of the day and say, oh, don't worry about paying me for the 10:30 a.m. patient because she didn't show up? Right? Of course not, right? You're paying for all. I like to think of it like an airplane. You're paying for the fuel, the flight attendants, everything. And so the one interesting use case I think for telemedicine is as you are confirming patients 2-3 days before and the patient says, you know what, I can't make it to this appointment, right? Maybe I have transportation, I have work issues. Will you be seen by telemedicine? This is an interesting strategy. Again, it's converting canceled slots into seen patients. And because for Medicare, you can get paid at 100% of the rate you would if you saw that patient in-house. It's a neat little strategy. If you don't want to go all in on telemedicine, you could certainly think about it as such. So what is the government in this, if you will, 2-year period that they've given themselves to figure out if they're going to pay for telemedicine? What are they thinking about? As you can see, on the positive side, care access is promoted, equity, because I don't have transportation issues, right? I can have patients come in, they can use their phones now to be seen via telemedicine. Or they don't have to pay for, if you go down to Atlanta and you have to pay $7 to park in Emory's parking lot, right? So there's some equity issues that are pretty significant. It's arguably cost effective, and those proponents say, you know what, this is safe and effective. The government, however, has absolutely said we're really worried about this from a fraud perspective, because there are some bad actors in terms of physicians out there that may this would give them the license to bill a lot. And so right now where we are with telemedicine, again, the law protects you from a reimbursement perspective through the end of 2024 for our federal payer, for Medicare. Many commercial payers are also still paying for telemedicine. However, it is really up to that health plan as to whether or not they're going to reimburse. So if you are interested in this idea of converting those canceled appointments into arrived appointments, of course you'd want to really check with reimbursement, but you could certainly do it for your traditional Medicare patients. The government has given itself basically about another 15-16 months to make a decision. And if you're interested, you can see some of the data that they are considering related to telemedicine. We also know, however, that the states are very involved in telemedicine reimbursement. And interestingly enough, Georgia is normally not, we're sort of with Guam on like the last things, we're number 49 or number 50 of every single ranking list. But for whatever reason, we are actually really progressive on telemedicine. And so indeed, Georgia's environment is very positive as it relates to telemedicine services. But what I've done is given you a link. So again, if you're interested in looking at this further, you can see this for our state. If you perform telemedicine services, your place of service code matters greatly. I'm assuming you guys are familiar with the idea of billing for a hospital outpatient clinic or a hospital outpatient practice, so it's HOC or provider-based reimbursement or provider-based billing. It's actually called a bunch of different things, but it's when you split bill. So you bill both a professional charge as well as a facility fee. So what's interesting with regard to telemedicine is that if you bill 10 place of service, which is telehealth provided in a patient's home, you are getting the higher professional fee reimbursement. If you bill place of service code 2, you are getting on the split bill side the lower professional fee reimbursement. And it actually ends up about 35 to 40% lower reimbursement. So please, if you do telemedicine, please, please, please use place of service 10. Make sure you're doing that, or otherwise you're leaving money on the table. So I do want to talk about the Medicare final rule. Again, it is 2,790 pages. It did come out the first week of November. So after Halloween, trick or treat, unfortunately, most of it is a trick. I always love it when it's a treat, but it ain't. And so the biggest trick for the final rule is that we saw a decrease in reimbursement, and it's a pretty significant one. The Medicare conversion factor is declining in 2024 by 3.4%. Slightly depressing to say that our colleagues on the hospital side, the facility reimbursement, are seeing increases of 3.1%. Why this 6-point swing? Why do we on the professional reimbursement side see so much, more depressing news for the coming year as it compares to the hospital? The reason is that the system, the methodology that was chosen many, many years ago basically means that as the economy expands, hospital reimbursement expands. It's kind of what's called a market basket rate. So hospital reimbursement, facility reimbursement, skilled nursing facilities, nursing homes, follows along with basically the economic index. While for us, we receive softened volume because the formula that was selected in the early 1990s depends on the number of beneficiaries. So what would that mean? As Medicare is expanding, providers basically have more patients to take care of with less money to do so. So again, it's really related to the methodologies, but it is our reality. So 3.4% Medicare reimbursement for 2024. What's frustrating about this, of course, even though we don't have a single payer system, is that many of our commercial contracts are tied to the Medicare reimbursement rate. And that is the same as being said with RVRVS. The resource-based relative value scale, that is Medicare. So if a contract says they are tied to RVRVS or tied to Medicare, those are synonymous. And again, you'll see the softening by 3.4%. Now, I'm still holding out hope that Congress is listening, maybe not to me, but to someone who is talking about this and saying, what the heck? Hospitals getting 3% increase, doctors getting 3% decrease. This makes no sense. And in fact, we need to make sure we preserve access to care. We don't have more physicians who make decisions to retire, who make decisions to move to concierge practices, who make decisions to reduce their patient panel. So we're going to step in as they have done 18 times in the past. That is, Congress has stepped in 18 times in the past to preserve that reimbursement rate. So still hope we have a few more weeks before the end of the year that we'll see those change. Now, interestingly enough, because the scale is tied to CPT codes, current procedural terminology, and we all use different CPT codes as specialties, there are some specialties that, despite this overall 3.4% decline, will receive a boost because the CPT codes that you use have received a little bit of an augmentation. And so the big winners this year are family medicine, endocrinology, and hem-onc. Now, this doesn't mean that when you see your remittances, you'll see an extra 3%. This is based on the government's analysis of historical claims sent in by the taxonomy codes that are represented by these specialties. IR, on the other hand, and this is, I believe, the 4th year in a row that we've seen some pretty depression in terms of reimbursement for IR, as well as vascular surgery. And of course, those two specialties commonly use the same CPT codes. So that's why they sort of live and die together from a reimbursement perspective. And for radiology, nukes, nuclear medicine, seeing that lowering as well. So I have provided all specialties. I apologize for the tiny writing, but again, you'll see these on your handouts. And you can see that every other specialty is estimated to receive between a -2 and a +2%. Again, a -2 and a +2% as estimated by the Centers for Medicare and Medicaid Services. So I have given you the source, where this appendix is, so that you can take a look at this yourself. Although I love to read, Becker's and Modern Healthcare, etc., I also love it when I can get to the horse's mouth. I can go right to the source to make sure that I'm receiving this information myself, and that's what I wanted to provide for you. Okay, I said there was going to be some silver linings, some optimism, and hold on to your hat. Here is where we're actually seeing some really exciting news related to reimbursement that will affect not all specialties, but most. The Medicare final rule does absolutely codify. So this isn't proposed, this is final. January 1st, 2024, we can start billing these CPT codes and be paid for them. For those of you who are familiar with coding, you'll know that a G code, that is G as in good, does signal that it's a Medicare, I'll use the term temporary code. I say that because most G codes then convert into a real CPT code. They go through the American Medical Association's review process. But in the interim, you can't bill a G code, for example, with Aetna. So I'm talking about Medicare here. I love the care navigation codes. The care navigation codes, CPT codes, are for all the work that you and your teams do related to making sure the patient is navigating through the discharge transitions of care, navigating the patient through getting community resources, for example. So this is really exciting because I love every time I can get paid for my staff's time, because the physicians are already completely burned out, right? If you say, well, one more thing, why don't you do some care navigation? They're going to go, I don't care how much you pay me for this. Like this, I'm done. I am here in terms of the demands on my time. So what I love about these codes are, this is really paying you for work that your staff is almost always already doing, and it doesn't impact or doesn't give you like, I have to have my doctor do all this extra stuff. So care navigation, here are your CPT codes related to that. I've got 4 new CPT codes, really exciting. Love this. Neurology, rheumatology, anyone who's dealing with a very difficult chronic disease, and there's a lot of engagement with the family, the loved ones, the caregivers, right? Think about how much time that you spend talking to a family about handling a patient who has just been diagnosed with a significant chronic illness. You can get paid for it. January 1st, 2024, we can get paid for caregiver training. Very, very exciting. And again, these are actually, interestingly enough, real CPT codes. I say that basically it means you can bill these with other non-Medicare payers as well. Why even do it? It does allow then Humana, Aetna, Blue Cross Blue Shield, etc., to say these services are being performed even if they don't get reimbursed. I say that because I work with a lot of practices that say, oh, Elizabeth, I'm not even using those codes anymore because ain't nobody going to pay me for them. And what we are doing then is we're perpetuating the insurer's perspective that the services aren't being provided. So I actually think that even if you aren't getting paid for them, it's really important to make sure that we document all of the amazing work that you and your providers and your team are doing. Caregiver training. Oh, this is a super cool code, G2211. I love this. It's an add-on code for visit complexity. You might be like, what the heck is that? Everybody is saying, what the heck is that? Interestingly enough, a couple of years ago, Medicare, CMS had introduced this code, and everybody said, oh, it's too much. It's too much. We can't do it. And a shock to everyone as they brought it back for January 1st, 2024 reimbursement. What this is intended to pay for, any specialty can bill for this, is relationship building for longitudinal care. What the heck does that mean? Think about a primary care physician. Think about a pulmonologist. We have a patient with COPD, emphysema, and there has to be time. In fact, the CPT code uses the term the cognitive load of establishing and nurturing the relationship with that patient. So it's sort of like, instead of a one and done patient, it's any patient that you would then be, again, establishing longitudinal care with. It's intended to pay the doctor for that cognitive load. Fascinating, huh? So it's an E&M, an add-on code to E&Ms. G2211, don't forget about that if you are particularly in a medical specialty. I think about Hep C, for example, and GI, brilliant code for that. So really think about this G2211. Community health integration, this is going to pay you for transferring the patient to community resources. Things you do today, but you don't get paid for them. Again, really great news with these. And then last but not least, love this, SDOH screening. Anybody familiar with the term SDOH? This is social determinants of health. What the CDC has been saying, the Centers for Disease Control, for many, many years, and a lot of folks in public health, is that the patient's economic conditions, the patient's education, their housing matters when it comes to healthcare. So physicians know that, but again, it just is not part of our ecosystem from a reimbursement perspective. Exciting news, you can get paid about $20 to $25 for doing an SDOH screening. For your annual wellness visits for Medicare patients, for example, you can slap that sucker right onto it. Annual wellness visit, of course, you should be doing not with a doctor, but with a nurse, because a nurse, under the supervision of a physician, can perform those visits. And this screening, which is basically, honestly, like a checklist, you can put it on a tablet and you can get paid an extra $20 for that screening tool. That is all done by your free employee, your patient. So I love these new codes. Really wanted to, I know I went over them very fast, but wanted to share that silver lining with you. Now, one of my go-to mechanisms for looking all this stuff up about how much I'm going to get paid for them is indeed the CMS physician fee schedule lookup tool. So I'm on this all the time, because the one great thing that Medicare does for us is at least it tells us what we're going to get paid. And so the reason I can't give you specifics in terms of payment is that Medicare actually has 83 different payments in the United States. Here in Georgia, we have 2 reimbursement rates for Medicare. We have Atlanta and the rest of Georgia. I know that's a little depressing, but that is exactly what the federal government divides our state. Atlanta and the rest of Georgia. So it depends on what CPT code what zip code you're enrolled with in terms of the fee schedule that is being paid for you for Medicare. Let me stop here, see if y'all have any questions. I know I'm going kind of fast. Wanted to spend a minute on that silver lining.
Really good information. It's funny that this was great about the telemedicine, because to me, in my experience, so many offices quit doing telemedicine, and I thought it maybe was based on lack of reimbursement. But I just wonder, why are the offices not doing that? With, I hate to say it, the struggles of the workforce, with people calling out. It's just, I can't wait to spread the word on this and encourage them to get back to it. I guess if they're not, and why? The only thing I think is maybe they don't have the staff to do it, or maybe technical challenges. But if I heard you correctly, they can just do, I guess, a phone or FaceTime or still bill that?
Yeah, that's a really good question. So I do find that workflow is part of the challenges, especially like from an efficiency perspective. If I can turn my operations hat, it's much more efficient to schedule a half day or a day for a doctor to do telemedicine. Going back and forth is very difficult. So I think that's one of the challenges, and it's why a lot of practices have just said, I don't want to do this anymore. And then secondly, there's a lot of unknowns related to reimbursement. And I do want to make sure that I mention, as I talked about telemedicine with the Consolidated Appropriations Act, that is specific to Medicare. Now, we actually do have a very favorable reimbursement from Medicaid in Georgia, but we do have some payers that will not pay it. So I think that also makes it, that extra layer where it makes it a little bit difficult to be like, am I going to get paid or am I not? So I do want to mention that.
I was kind of going back to what you said. You said if you use the place of service 10, that's
Yes.
the highest reimbursement.
Correct.
But some payers will only let you do place of service 2, which is the lowest. So is that meaning it's lower than doing a 99213 in office?
Yeah, it's a good question.
213 with a place of service 02, is that less than doing a 213 in the office? I guess it's
It would, I don't, without knowing that fee schedule, but it likely is.
that's
Mhm.
probably.
Yes.
Do you have any information that you can pass on about the LTA that was passed, the Leukemia Treatment Act? I know you're adding a lot of CPT codes.
I don't. No. Thank you for mentioning that, but no, I don't. I'm happy to do some research on it, but I don't know about that.
Yeah, Medicare will not start covering compression garments for patients.
Oh, interesting.
Lymphedema.
That's awesome. That's awesome.
Yeah, maybe to Kathy's point is that when the telemedicine rules changed,
Mhm.
if you were considered like a more standalone physician practice, even in a Northside network, telehealth was still available. But for my department, which looks like a medical office practice, we're in the hospital umbrella and we couldn't do it.
Got it.
Even though it made sense for our patients and all that kind of stuff.
Right.
We would not get reimbursed for it, so that's part of the problem.
Yeah, so it's a hospital outpatient billing or provider billing, provider-based billing issue. Yeah, so there's definitely a lot of complexity, but the window is there if you can do it. Okay, so I did want to mention, and speaking of telemedicine, there are a lot of favorable preventive services. Now, I know this is primarily for primary care and medical specialty services, but did want to point out this great chart that will show you what you can get paid, the frequency, and whether or not you can perform it over telemedicine. So this is things like smoking cessation counseling, et cetera. And again, it's something that I always encourage, like at least once a year, to just kind of go poke around this, like, medical nutrition therapy, MNT, is paid very, very well. And a lot of endocrinology practices don't know that or don't know how to code and bill for it or what the frequency is. So again, just kind of worth, especially if you're a medical specialty or primary care, poking around a little bit to make sure that you're getting paid correctly for all of the services, all of the work that you're doing. Sequestration, you guys remember this, that's that pesky little 2% that Medicare does take off of all of the payments that it makes to providers as well as healthcare facilities. In a deal that the Congress made several years ago, they basically extended the sequestration reduction from 2025. It was supposed to be up the year after next to 2030. And they did that to basically pay for some of the reimbursement opportunities that we had during COVID. So we will still see sequestration. You'll see that under the CARC or SARC to CO253 on your remittances. And so indeed, No Surprises Act has been a little bit of a disaster from the federal government's perspective. And I say that because they did have a independent dispute resolution in place, or an IDR, and I'm not sure they quite thought about all of that. The IDR comes into play when basically, as the name sounds, there is a dispute between the healthcare provider or facility and the insurance company as it relates to typically out-of-network billing surprise services. So more to come on this. We're seeing a lot of shift with the government right now to really shore up the problems related to independent dispute resolution. And you can see just a few weeks ago, a proposed rule was issued to try to resolve that. So if you're billing emergency medicine billing, for example, or you have a lot of out-of-network billing, you may want to follow this very, very closely. Now, I do want to spend just a few minutes on the Quality Payment Program. The Quality Payment Program, or the QPP, sometimes we call it MIPS, because that's kind of the component that most physicians do perform or most physicians do participate in that program. It's the merit-based incentive payment system. So this is a program that's been in place since 2017 is when the law was passed, and we began 4 years ago participating. Now, interestingly enough, it is really for those of you who have high Medicare business, and that is $90,000 or more of total allowed charges through Medicare Part B. If you don't, you probably don't have to worry about this program, but either way, you may want to just pop up the website. You type in your provider's NPIs to see, that's National Provider Identifier, to see whether or not they have to participate. The reason to do that is because you do have 9% penalty on the table if you do not participate successfully. 9% is a lot on top of the 3.4% I already just announced. Now, for those of you who've been participating in the QPP or MIPS in the past, you have known that, we've gone all in. Physicians are competitive people. And so we've hired people just to do this MIPS program. And promises were made of 10, 12, 14%. I think at the beginning it was either 28% bonuses that we could get by participating successfully. That has not come into play. The very, very best we've gotten, the highest, is 1.87%. I don't know about y'all, but that's pretty depressing. And the reason it is like many government programs, it's budget neutral. The losers pay the winners, and doctors aren't losers. So there's really not a lot of money for the winners at all. And it's important to recognize that even that paltry 1.87% is gone. So I'm really not very high on this program in terms of maxing it out. I'd ask for y'all to think about, if you do have to participate, what's the business case for me getting a perfect score? It's really hard to get a perfect score. There's a lot of money going into getting a perfect score, and you're not going to get any money out of it. Now, please make sure you walk out this room not hearing me say don't participate at all. You want to be successful. You need to get to the threshold to make sure you avoid the penalty. But my point is don't go nuts about this program. Just make sure you're kind of skimming by, because you're not going to gain not even a dime by getting a perfect score. So you can see this changes. This is an example. I know we have GI here, for example, and actually this would be for primary care too. We are losing the colorectal cancer screening quality measure, which a lot of providers use. So I'm only giving you one example here, but please know that the quality measures for the program change each and every year. So it's really good to keep yourself updated on them. Now, the good news is that if you don't want to participate and you don't want to be penalized, mark this website, which is basically the website to get yourself out of all of this stuff. You can apply for extreme and unusual circumstances, and you don't want to participate because of that. I don't know about y'all, but an extreme and unusual circumstance is COVID. And I'm in 2023, we still had COVID, so that's how I'm going to apply. The application takes less than 5 minutes, and indeed, it gets you out of this penalty. The other nice part is if you apply and you report, you can actually have the application overridden. So it's kind of like an amazing Plan B plan. We do know that a number of counties, this doesn't include Forsyth, were automatically excluded, because if you do have any sort of natural disaster that comes into play that's sort of like a level 3 emergency, CMS goes ahead and takes you off the table so you don't have to participate. Now, we do know that you do need to get to 75 points in 2024. So if you do decide you don't want to apply for that waiver, but you really don't want to go all out, then please, again, at least get 75 points to avoid that 9% penalty, because that is really, really difficult on top of all your Medicare reimbursement. Now, I love to get this book. I have mine in my office from the American Medical Association because it gives you all of the information about the CPT coding changes, particularly if you're in pediatrics and primary care and you're giving immunizations. Please make sure that you get the book this year because there are a ton of changes related to immunization, reporting, and a new vaccine administration code. So again, this is 2024. We know the 15 and 25 and 40 minutes that were associated with the CPT codes, the E&Ms, 99214, 99215, etc. Those time ranges are actually being removed, interestingly enough. And the definition of a split and shared E&M visit. So if you're oncology, for example, and you have a lot of split shared E&Ms, which typically happens in the facility setting, definitely want to get the book, or at least look at your specialty society as they describe more details about these CPT coding changes. So I mentioned that I wanted to talk about the competitive landscape. One of the big things that's happened during COVID is we've really been able to enable the doctor in our pocket. Everybody who walks around basically has a physician very easily accessible in their pocket, i.e. through their phone. And so COVID has really inserted this into the ecosystem, particularly with the younger generations. I teach at Emory University and my students tell me, like, are you kidding me, Elizabeth? I would never actually go into a doctor's office. I would always begin with a telemedicine, or for them, they pick up their phone and they go ahead and just, scroll through, they get their little appointment online, and they only go if they need to see a specialist, for example. Like, the front door to care is changing. The other thing that's happened in addition to the consumer expectations changing related particularly to the younger generations, is the fact that there's been a ton of money poured into healthcare. This is not just on companies that are on the stock exchange, the Walmarts, the Walgreens of the world. This has also included a lot of early stage and new companies. And indeed, interestingly enough, these companies have joined forces with payers, which is really interesting. Cigna, for example, bought MD Live. So Cigna actually owns its own telemedicine company. So you're like, well, why, for example, are you talking about your students who could do telemedicine? Like, how do they even get paid? Well, the reason they get paid is Cigna is the students' health insurance, and Cigna has its own telemedicine company and contracts with providers to do it. So it's no co-payment for the students at all. So the dynamic, I think, is really important to understand, particularly because it used to be just the urban markets that were dealing with this new phenomenon. That has changed. In fact, the term, if you just Google healthcare deserts and private equity, you will see a ton of hits. This is the new thing for private equity. This is companies that are pouring in a lot of money into healthcare. They really, really want access to Forsyth County, to healthcare deserts. You can see I just pulled this big box care. The gap is being filled, but not by traditional healthcare outlets. It's being filled by Walmart. So Walmart, for example, just partnered with the largest healthcare system in the state of Florida, Orlando Health. It's sort of like, maybe you would think of it like Piedmont in Atlanta. And so Orlando Health is the provider for Walmart in the greater Orlando region. So we're starting to see some really interesting kind of changes in this paradigm of care, particularly related to these healthcare deserts. Dollar General has really moved into healthcare big time. You can see they actually have healthcare services now. They do with mobile vans. So they go out in several states, including Tennessee, with their vans and see patients in the parking lot through Dollar General. Best Buy Health years ago actually bought a nurse call center, and they did that because they saw the trend of remote patient monitoring, which pays very, very well. And so Best Buy can now send out the Geek Squad for a patient's pulmonary function test. So again, this paradigm is changing everything. And why should we care? You've got plenty of patients, I'm sure. We know that supply and demand is really out of whack right now. Is everyone, all that pent-up care during COVID is now hitting your offices. It's really, really, really saturating medical practices today. And you may say, well, that's okay. Walmart, you can have your thing. But what I want to make sure we recognize is that the relationship between employers and payers is very dominant. So when Delta, for example, goes to Amazon and says, I want you to manage my care, there is a trickle-down effect to us. And maybe if you're a specialty practice, you might start getting referrals from the Geek Squad. So indeed, we may have these fax machines that we sit there and we wait for all of our referrals to come through. Y'all, I don't know where we're going to be able to buy fax machines 5 years from now, let alone service them. So everything is changing around us. And I think it's really compelling to at least acknowledge those changes and remember how important it is for us to maybe not be fighting with Walgreens, but to make sure we continue to provide availability, accessibility, and convenience for our patients so that we can compete. The reality is that the front door to care is changing. It is becoming, like my students do, the phones. It's becoming ChatGPT. They go on to ChatGPT and they put their symptoms in, and the ChatGPT gives them a diagnosis. And you may think that's crazy, but actually initial studies have shown that ChatGPT is actually pretty good at diagnosing, again, simple things. So it's not that crazy. And in fact, we can see that claims volumes, interestingly enough, urgent care climbs, but our traditional hospital ER claims and primary care claims have dropped. So patients are making choices to go into non-traditional avenues for care. And our payers love it. They got a lot of money during COVID. It's not like United Healthcare in March of 2020 called and said, oh, I see that you can't actually go out of your house in the state of Georgia. Therefore, you cannot go see a doctor. Therefore, don't pay your premium this month, right? United was like, bring it on. They kept collecting those premiums, even though none of us could get health care. And they did it for 3 years. And you can see what happened to their stock price. It went up and up and up and up. And the reality is they have an economic incentive not to pay us because they've gotten the money already. It's the dynamic of health insurance in the US. And so what's really challenging is that on Wall Street, they're all saying, listen, we got to make sure, look at this, y'all, the stock price of United Healthcare. And I could have put Cigna, Aetna, any one of them up here. It has absolutely gone way, way up in the last 3 years. And so what's happening to y'all is denials, big time. The data is showing, and you can see on these slides, that both the facility side as well as the professional side of healthcare, we are seeing a surge in claim denials. And it's not surprising when you consider what the dynamics are that I've just discussed. 15%, if you can believe it, of outpatient professional claims that are indeed denied for commercial payers. And I know you're feeling that in your own offices, but indeed it is happening. Now, my hope is that all of this post-COVID surge of demand, GI, GYN, orthopedics, we could go on and on. There's a massive amount of demand that you're dealing with. Is that hopefully the tables will start to turn. And like we could 20 years ago, we could go to conferences like this and learn how to negotiate insurance contracts. Today, I don't know about y'all, but I look at that on the agenda and I'm like, oh, that's cute. It's not going to work. I'm not really sure why I'd spend my 30 minutes learning about it because it's not feasible. My hope is that is changing. My hope is that is changing. So indeed, we've gone over these trends, and I know I've gone almost to the top of the hour, and I want to give time for your door prizes, which I know that's really the reason you're here, but I hope at the very least you've been able to learn more about the environment, to see a little bit about some of the challenges that we have, but also learn about some of those opportunities. Thank you for allowing me to do what I love to do. Sure, as Laura's coming up, any other questions that y'all might have, or do we have one? Yes.
You had mentioned that.
Wait, say your name and practice.
I'm Bill Sears, and I manage Newtown Medical Associates now for And you had mentioned something about in 24, the time being taken away.
Yes.
Can you talk more about that? You talking about the time, using the time that was spent with the patient to increase the level?
Yes, yeah, so the time, the actual, and the descriptors are being taken away. So it'll be interesting to see how, what that does in terms of change. We just found out about that very recently. So it's just basically, as you know, the physical exam was taken away. Like E&M codes have changed massively in the last 2 years. So this is just sort of the next phase about that. So my suggestion would be to learn more about that is that AMA coding changes. I was looking at the manual the other day, and it really goes into a lot of description about what that change means. And what I love about that book, and I think it's like $79, so it's not a huge commitment of resources, is it walks through different scenarios, et cetera. So if I may defer your question, which is about the time issue related to E&Ms, for office-based E&Ms to that manual. Any other questions? Well, again, thank you so much. Laura, I'll turn it back over to you.
Thank you, Dr. Whitaker. Y'all join me again in thanking her for sharing all that. I don't know about you guys, but it certainly felt different than last year and a little more of a roller coaster of feelings. So I can't use my exact same joke because this year we did have some silver linings that I appreciate you sharing with us, Doctor. And she mentioned we'll have her slide deck out to everybody so that the resources listed on there will be available. On your tables and for our virtual audience on the screen, regardless of the silver linings or the Dollar General Geek Squad care side of things, let's have a party, shall we? So y'all please make plans to join us on December 14th in the Women's Center Galleria for the annual Mingle Jingle. It really is a great time for us to flip the coin and celebrate a bit together. There is a QR code on the screen on your tables for you to let us know that you're coming. Please do that if you are able to join us. It's an evening event, a great deal of fun, and just a night for us to kind of celebrate the holiday season together as an association.